Hello everyone, this is Bob Browner. I'm here to explain the Nebraska Federally Qualified Health Center Cancer Screening Initiative that you'll be taking part of over the next 6 to 7 months. This is part of a contract that you have with Nebraska Department of Health and Human Services. We're also hired as part of this contract to help you improve your cancer screening rates. So all of you have a contract that looks like this, and the deliverables for the contract that get you paid are actually the same things that also qualify for your physicians for both CME and maintenance certification credit, and that's what we'll be talking about for this. This is also part of a larger effort across the state. 80% by 2018 is a national effort to improve colon cancer screening rates in the nation. A lot of groups in Lincoln and Nebraska wider are working on a similar project, and I'll kind of show how this came about. So the goals of this CME and the maintenance certification we're going to start with basically focusing on your colorectal cancer screening rates and your cervical cancer rates. These are based on national quality forum measures, which are identical to UDS measures that you already report on to the federal government as federally qualified health centers. At the start of this project, we'll be pointing out this form that we'll have you start with. Basically, the goal of this is to start with the baseline, which your clinic should be pulling here shortly. You'll then try and set goals for the coming months to try and improve your cancer screening, which we'll talk about during the presentation. I've been working with a group of Lincoln and surrounding clinics on a similar project this year. The yellow dots there are where all these 30 clinics started at the beginning of the project at the beginning of 2016. Blue dots are where they are in cancer screening this summer, and they're all in their third round and gathering that data as we speak. We're also a part of a broader project to improve cancer screening, and I'm working with Great Plains Quality Improvement and Ted Frazier, who has access to Medicare claims data, to see how each of the health department districts are doing. Our goal as our Lincoln project was to see if we could have our screening rates be better than the rest of the state, and so far we're meeting that, but we'd like the rest of the state to also do similar projects. We're also working on breast cancer screening in the same manner. We'll also be pulling those for your clinics in the coming months to see if we can pull these out of their EHR as well, but there's not a standard UDS measure for this, so we'll have to build those within your EHRs. Again, breast cancer screening we're also following at the state level. So the benefit of this project to you, first and foremost, is improving the care of your patients. You all take care of Nebraskans who are in the most need of better care, so we want to try and make this work for everybody across Nebraska. You're also going to receive funding from the Department of Health and Human Services in your contracts, where you'll receive between $60,000 and $65,000 of funding to help fund care coordination, some health education for your patients, and fund your quality improvement work over the next 7 months. As a side benefit of this, at no cost to your clinics, you'll get 20 hours of CME credit that works for physicians, nurse practitioners, and physician's assistants. Also, for physicians, it's qualified as a Part 4 maintenance of board certification for their maintenance of board certification for both family physicians and internists. A side benefit of this will also have comparable data to your peers across Nebraska, and we're hoping to divide this up and analyze by type of insurance, race, ethnicity, and language preference to find out what works for different populations. Each of the 7 federally qualified health centers in Nebraska has different demographic profiles. We'd like to see if this is something that we could use to help with specific races and ethnicities. We'll also be using this project to guide future state projects. So the educational curriculum does require a model for quality improvement. The model of quality improvement we'll be using is DMAIC, which comes from the manufacturing and IT worlds. This is the project framework I've been using for the last 10 years, except I modify it from control, and instead of using control, which fits more with an assembly line, more with communicate, which is more of an issue amongst medical clinics. This has been used in healthcare and other settings. This is a study in Germany for German hospitals where they use DMAIC. They focus on what I sometimes call the ultimate quality measure, which is dead, not dead, and it worked across the board for these projects over the several years with these German hospitals. I also use this with my time when I was the Chief Medical Officer of the Southeast Referral Physicians Alliance Accountable Care Organization. It's abbreviated CERP-ACO in Crete. We were in 2014 one of the top 10 highest quality Medicare ACOs in the country. This worked for them. I think it'll also help work for you. So DMAIC starts with D is define. So definition of quality, again, like we mentioned earlier, is the UDS measures that you're already using for colorectal and cancer screening and cervical cancer screening. So we'll be pulling these measures with the assistance of your staff and EHRs. You will set your targets for June of 2017 for improvement. So for example, you might say that, let's say you're starting at 30% of your patients screened, you might set a goal of getting 40% screened by June of 2017. After define is measure, analyze, and improve. So once you've measured quality, you then focus on what could be better. And so I usually tell people that it's often helpful to track initial screening rates by provider to see and figure out what's working and what's not. The most important place to focus is the people who have not been screened. In this slide, it's a red bar, and finding out why are they not getting screened and what can we do to improve that. So figure out why they aren't screened, figure out things to improve this. Could it be tracking patients down who haven't been screened? Is this something your care coordinator could do, your front desk could do? When your patients are at your clinic, are there alerts that you could put in place, better ways of rooming the patients, or some reminder systems that could be developed? Those are things you'll talk about as part of your plan to improve the care of your patients. One of the most important things in clinics, though, with quality improvement is communication. It requires some open discussion. You'll need to discuss this more than once. Also, it helps to use some positive competition and avoid what I sometimes call a rank and spank method. It also requires that a team approach. Everybody in the clinic should know the role they play in improving quality. We'll talk a little more about that later. Timeline for this project, November and December 2016, this is your initial site visits, which we'll be scheduling in the next few weeks. December 2016 is the baseline data and when you're supposed to start the CME and part format certification. There are two forms you'll be turning in, which I'll discuss shortly. March of 2017, we'll pull data again to see what improvements have been made and modify the plan if needed. And then May and June, we'll do a second site visit, and you should pull your quality measures at that time and discuss what's happened, and then you'll complete the Part 4 certification in CME in June of 2017. So as far as using positive competition in your clinic and avoiding a rank and spank, what I mean by that is that when you're looking at a snapshot in your clinic and hopefully breaking this down by provider, the focus isn't to blame this person for not doing as well, but to find out why is this person getting better results than this person. Sometimes it's an honest mistake where somebody wasn't trained where to put colorectal cancer screening results in the EHR, so it's simply a bad report. Sometimes there's a doctor that has a higher number of patients that are uninsured, so therefore has a harder population to work with, so it may not necessarily be their fault that they're doing worse. It could be this person actually here has just developed a better way of explaining to their patients why they should be screened. They may have a better way of rooming the patients. The key is finding out why is the difference and what can be improved. What you often find out in clinics that do a really good job is that all providers end up being pretty similar because a lot of the processes put in place work for everybody. But again, you go back to try and find out what works and let's make it better and not focus on blaming anybody. When you start these types of projects, one thing you often find is that when you start out, your data is not very good. This is an example about 11 years ago when I was working with our residency program clinic in Lincoln. So Lincoln, somewhat similar demographic profile to your clinics. We took care of about half of the Medicaid patients in town at that point, and a lot of refugees from the Sudan and other countries. When we first pulled our data, we found out that our Pneumovax rates were actually pretty bad, at least by this report. However, this report is falsely off. What happened is that we put the EHR in here, and we didn't move all those Pneumovaxes into the electronic medical record. And so these aren't real numbers. You'd see a little false bump. Basically, that's when we had flu season. We'd catch a few Pneumovaxes when we were giving people flu shots, and then you'd see the same thing here. But still, it's just generally bad data. So we went back in and cleaned up our data as we started these quality improvement projects. Found out that our real numbers were actually not too bad, around 57-58% of patients with Pneumovaxes. We then started working on things, putting in some rooming the patient protocols, standing orders, some outreach to patients to remind them that get their Pneumovaxes, and within a few months actually got to the point where our pneumo vaccination rates were very competitive to folks and even private practice clinics across the country. We found similar results here with the cancer screening project here in Lincoln. If you see, for example, this clinic here started with what was essentially just bad data, and as they cleaned up their charts over the first 3 months, found out that when they got the GDSID data pulled, their cancer screening rates were very, very competitive. But they couldn't prove that because their EHR was such a mess when they first started. But as cleaning up, they found it was better. This clinic here actually had more than that. It wasn't just that they didn't have their EHR, didn't have colonoscopies and FOBTs in the right place. It was just that they also had some other problems with their reports. This clinic is half the size of this clinic, but somehow had tons of patients in their reports. It turned out that for the last decade, they hadn't been inactivating patients when they moved away or when they died, and so they were pulling measures on people who weren't there anymore, so of course they hadn't been screened. They also had some problems with pulling the reports where duplicate charts were often created, and so it made their results falsely low. I was just at this clinic, and their current rates are actually closer to here now that they've got everything cleaned up. And as they've been starting to spend the whole year actually with the reminder systems, they'll actually be a very competitive clinic by the time they're done with the project. Sometimes it's good to actually spend a little time looking at why aren't patients screened. So sometimes it's because, like before, they left the practice and we haven't deactivated their charts. We have often high no-show rates in clinics with low-income populations because of transportation and other issues. Or we do have a reminder system in place so that when people no-shows, we make an effort to get them back in. Sometimes people actually show up when we don't take care of things, so sometimes it's a missed opportunity, but trying to find out why aren't patients getting screened in your clinic, and are those things that are fixable. So part of the CME, the first thing you're going to do, like I mentioned earlier, you're going to fill out this form. What are your baseline screening rates? What's your goal? And start creating a plan for how you're going to make things better. The second thing you'll need to do is create something called a workflow diagram. That can be as simple as something like this, where people just put some sticky notes on a white paper and kind of map out what they're going to do. When the patient shows up, how do we check to see if they're screened? If they're not screened, what do we do? It can be something as simple as this. However, I'd highly recommend that you turn it into a written form like this. The reason being is that once a plan is made, it can be distributed amongst your staff. Oftentimes, clinics, the decision is made at the staff meeting, but isn't necessarily communicated very well to the rest of the staff the following day. So if you turn this into a written plan, it's easy to push out to the rest of the folks in the clinic. It's also something that's modifiable later on, and we'll talk to you a little bit about at our site visit about creating these reports and trying to do this. Within your state contract, there actually are listed things you're supposed to consider, things like team huddles, provider feedbacks to show them how they're individually doing, which we showed earlier, creation of standing orders, maybe involving your community health workers, the reminder systems, depending on what your EHR is capable of, for example. There's also fundings for some health promotion or marketing, and we encourage you to actually do this with other agencies. Here in Lincoln, People's Health Center is actually considering working with their ethnic community centers, El Centro de las Americas, which is our Hispanic Community Center, and the Malone Center, which is our African American Community Center. They also have a grant to do very similar things, so they'll probably be pooling their efforts and funding and hopefully achieving better results by working together. Some people say, well, why don't you just give us a workflow diagram? And the reason I don't think that works is a couple things. First of all, is I don't necessarily know how your staffing model is set up. You may not have a care coordinator position yet, for example. You may have someone who's very attuned at doing this in a different position. Also, it depends which interventions you want to consider. Some interventions may not be feasible because of your EHR or other reasons. And so it's really up to you to kind of figure out which are the best solutions for your clinic based on your staffing and what your capabilities are. There can be exponential number of possible combinations, and other studies show that clinics that create their own workflows do a better job than if someone just tries to helicopter and dump on a workflow onto them that they didn't have a lot of role in creating. So once you've created your own workflow by seeing which staff are actually going to be the key people, how they're going to work together, what interventions you're going to use, that's what you're going to use to assess to see how your outcomes go. A couple of things just for reminder, some of you may already know some of these things, but for colorectal cancer screening right now, there are three options that are currently recommended by experts, including U.S. Preventive Health Services Task Force and the Primary Care Medical Societies. Approved ways of screening are either colonoscopy every 10 years, FlexSig every 5 years, fecal occult blood testing, or FIT testing yearly. DNA is actually still new enough that they're not recommended by the U.S. Preventive Health Services Task Force, so we encourage you to use one of these as opposed to the DNA testing. Cervical cancer screening is changing a lot. When I was in training, it was simple. It was just basically pap smear every year. But due to improvements in HPV vaccination and cytology and other things, the interval has dropped, and so either of these measures are applicable for average women. It's up to you and your clinical judgment and also patient choice which of these they're going to pick. Breast cancer screening we'll get into a little as we go on the project. Right now, the current recommendations from U.S. Preventive Health Services Task Force and the Primary Care Medical Societies is every other screening between the ages 50 and 74, but as you probably know, there's some controversy with American Cancer Screening and ACOG and the radiologist having somewhat different recommendations, which is kind of confusing for patients, unfortunately. It's up to you. None of this project dictates that you use any of them, but it is important to recognize that there is some controversy right now. So lessons learned in summary, I worked at a conference with some experts from Michigan. One of them, Mary Ellen Benzik, is a family physician who's worked with dozens of primary care medical home projects across Michigan. Michigan has more medical home projects than any other state. And I asked her would she say was the difference between clinics that did well and didn't do well of all the ones she'd worked with. Essentially, she said physician leadership is key. There needs to be a lead physician that's involved in the project. However, they also need to delegate a lot of the work to a sort of a lieutenant. Oftentimes, it's a care coordinator position or a nursing lead who really gets a lot of the work done. They need the backing of the physician, but a lot of the work is actually done by the staff. Second was to measure but keep it simple. You can't do 22 focus measures at once, but pick a couple of them, work on them, and do well, and then move on to the next thing. Third was to make sure that the whole clinic is involved and understands the process, that the back office, manager, care coordinator, nurses, everybody has to understand what's involved with quality improvement. Last thing is that the team does need planning time like the meetings we'll be having shortly. You also will need to meet on a periodic basis, and we'll talk a little bit about that at your meetings. So again, in summary, this is the model we'll be using. If later in the year, early next year, you're interested, we'll have other options for talks on staffing for quality improvement and how to use quality and not. We'll see you soon, and let me know if you have any questions.